Good afternoon and welcome to ICE webinars. Today we are joined by Nancy Davis, Director of Accreditation for CT at the Intersocietal Accreditation Commission. Nancy brings over 30 years of clinical experience as a CT, MRI and mammography technologist to her role at the IAC. Throughout her career, Nancy has held various leadership roles where she oversaw daily operations of radiology clinics. She has also been responsible for creating and implementing policies and procedures involving healthcare compliance as a HIPAA compliance officer. Now, our ICE webinar, would like to thank the IAC. Since 1991, IAC has operated as a non-profit, accrediting facilities that provide vascular testing, echocardiography, nuclear, MRI, diagnostic CT, and intervention-based procedures under its mission of improving healthcare through accreditation. More than 14,000 IAC accredited sites have implemented standardized and optimized processes, experienced cost reductions, and most importantly, continuously improved their patient outcomes. So to learn more about IAC, please visit intersocietal.org. Now, just a reminder to save the date for our 2026 ICE Expo, which will take place at the San Antonio Marriott River Center on the Riverwalk in San Antonio, Texas. That will be February the 20th to the 22nd. The Imaging Conference and Expo is the only conference dedicated to imaging directors, radiology administrators, and imaging engineers. ICE offers valuable CE credits from the ASRT and ICI and is a unique community of key decision makers and influential imaging professionals. So for more details, please visit attendice.com. Now, ICE Magazine is excited to announce our first annual Diamond Awards. In December of this year, we'll be announcing the 8 imaging directors or managers who have been nominated and chosen by our ICE audience. To nominate an individual or yourself who you feel should be highlighted for their great leadership skills in the imaging healthcare field, please visit theicecommunity.com/ICE Diamond. The deadline for nominations is May the 16th. Okay, today's webinar is eligible for one art category A CE credit by the AHRA. You can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. Now, you must complete the survey to receive your 1 CE credit, and you'll be able to download the certificate directly from your computer once the survey is submitted. Now, if you have any questions, you can reach us at webinar@mdpublishing.com. We'll be wrapping up today's presentation with a live Q&A, so please submit your questions anytime using the questions feature on the webinar dashboard. Let's kick off today's webinar by giving away one of our ICE gym bags to the attendee that can tell me the answer to the following trivia question. As Easter fast approaches, what flower is considered the symbol of Easter? Answer now using the question feature on your dashboard, and I'll reveal the answer at the end of the webinar. Now, as I mentioned earlier, Nancy is our presenter today, and she'll be discussing tips, tricks, and tools for improving quality and safety. So, Nancy, you may begin whenever you're ready.
Well, thank you so much for that wonderful introduction, and thank you, everybody, for taking the time to attend this presentation. My name is Nancy Davis, as the introduction said. And today we're going to have several goals for our learning outcomes. During this webinar, we are going to discuss how to choose team members that will strengthen your quality and safety efforts. We're also going to look at how to use the 4 C's, what I call the 4 C's, to improve quality and safety in your practice. We will also learn how to evaluate outside quality and safety stakeholders to choose best options for your practice. And then we're going to take a little detour and lighten things up and talk about some safety issues that were faced by radiology pioneers. And then we will explore tools and resources that can assist you with your quality and continuous improvement efforts in your practice. My only disclosure is I am the Director of CT Accreditation at the IAC. A little bit about me. Wow, that was such a great introduction. I don't really have much more to say. Just a bit about me, though. I attended X-ray school the program at Johns Hopkins School of Medical Imaging. And I'd like to say that was back when we still used film and a Bucky to create images. And actually, my junior year, PACS was the futuristic highlight of RSNA. My background is in medical imaging. Most of my career, I was performing CT and MRI, so those are my main modalities. And before accepting a full-time job at the IAC, I did work for about 10 years for the IAC doing case review, and I also was the site auditor for IAC for CT and MR. So if you are accredited or were accredited by the IAC and you had an on-site audit, I may look familiar. I probably showed up. Also, I was a radiology manager and I was a HIPAA and compliance officer for a private practice. Also, during my tenure, I spent time at a large trauma center and inner city hospitals. I've been in medical imaging for about 30 years. I like to say compliance is my jam. So now that you know actually a lot about me, sorry about that, I'd like to just know a little bit about you. I wanted to know if you could tell me which of these options on this poll best describe your role in your organization. Outpatient practice manager, quality and safety officer, modality manager or chief technologist, a physician's practice manager, or a hospital administrator. I'll just give you a few seconds to answer that.
Okay, Nancy, I am closing the poll, and the answers are you have got 14% are outpatient practice managers, 19% are quality and safety officers, 33% are modality managers or chief technologists, 33% are hospital administrators, and you haven't got any physicians practice managers.
All right, so a good mixed bag, and I am sort of guessing, I should have said more than one because I know when I was in private practice, I wore many of those hats at the same time sometimes. So I'd like to start this discussion by asking you to take a few minutes of reflection. And what I'd like you to reflect on is your why when it comes to being a medical professional. I know probably some days now you wonder, why did I become a medical professional? But I want you to think about when you first decided to make medicine your career. Why did you pursue medicine? And what did you hope to accomplish? What mark did you want to make on the world? And then I want you to think about your current practice. What is your practice's mission statement? And what is your current office culture? I am pretty sure your why had to do with helping others, healing people. Maybe you had aspirations of helping create a healthier community. I know for me, I was kind of at a crossroads in my life trying to figure out what I was going to do. My mom got sick, and I had to take her to a lot of medical imaging appointments, and I became very interested in that, and I realized what an integral part of her healing journey the medical imaging professionals were, and it really piqued my interest. Plus, back in those days, you had a newspaper that you had to look at for jobs, and my dad would always say, when I said I wanted to do something, get the paper. And so I brought the paper to him, I opened it to the one edge, and I said, I'm going to be an x-ray tech. And at that time, it was sort of like now, there were plenty of jobs, and that's basically how I got started. And I'm hoping that you have a mission statement that focuses on providing safe, quality care to patients, and that your current office culture is one of compliance, teamwork, and safety. But if not, do not despair. We are going to work on these things today. We all want to provide excellent care for our patients. But even though we have these goals and reasons for doing what we do every day, the fact is that serious safety incidents involving medical imaging are happening at an alarming rate. If you are an MRI technologist or an administrator, this is your worst nightmare. Think you're safe because you're in another modality or in an outpatient setting where there's no hospital beds? Think again. These things can happen just as quickly in those scenarios. And what should be most concerning about all these incidents that cause significant harm to someone is that every one of them were preventable. We all have the goal of providing good, safe care to the patients that entrust themselves to us. The question that should call us all to action is how? How do we assure that everyone has access to safe, quality healthcare? Before we really dig into this subject, I'd like to better understand what challenges you face when it comes to quality assurance and patient safety. Please answer the poll by indicating all areas that you find challenging. Completing your accreditation application, creating effective policies, finding easy-to-use QI and peer review tools, and getting buy-in from your staff on quality initiatives.
Okay, Nancy, I'm going to close the poll. And your numbers this time are, you've got 13% on completing your accreditation application, 20% on creating effective policies, 53% on finding easy to use QI and peer review tools, and 47% of getting buy-in from staff on quality initiatives.
All right, well, that sounds like this webinar is really going to be going in the right direction and giving you some help. So I like to say that quality and safety is a team sport. In today's healthcare environment, it takes a cohesive unit to be able to successfully care for your patients. Everybody has to be involved. Because of this, every team member must do their part to assure success. It is important to remember that safety and quality is everyone's job, and all staff should approach their job with these two goals in mind. Yet the truth is, not everyone will have the same level of commitment to these initiatives. To counteract this fact, you need quality champions in your office who help to assure that the outcome is a safe environment where patients get the quality care that they deserve. Notice, I did not say it's the office managers or the lead tech or the administrator or the safety officer's job to make sure everyone follows policies and procedures. Yes, it is ultimately leadership's job, but having the right safety and quality team and procedures in place will assure that you will not have to face the task alone. Remember, there is no I in team. Those who are passionate about quality and safety will be your quality and safety team, your compliance champions, if you would. For those of you with small practices, this may be only 1 or 2 people. For larger groups, it really should be more. So who's on your team? Who are the main players on your quality and safety team? Who else is on the roster? To start, like a team needs a captain and a co-captain, you need a medical director and a technical director, or perhaps in your office, you refer to this person as a lead technologist. There is always a physician who is the medical director of your practice and your accreditation. This individual helps to ensure quality and safety by overseeing all policies and procedures that pertain to your entire practice. They are ultimately responsible for the safety of all the patients and staff and the quality of all office visits and procedures performed in your practice. The technical directors or lead technologists are individuals who have extensive experience in the modality that they work in. They are also the people who most likely are assuring what the medical director is overseeing. These individuals work with the medical director to assure that all quality and safety procedures are adhered to by the staff. But we all know that with the exception of tennis, figure skating, wrestling, and maybe pickleball, a team needs more than just 2 players. And because of this, to be successful, most managers should look at their staff and identify those team members who are passionate about quality and safety. Remember, these are going to be your champions. These champions can be found throughout your team. They could be staff technologists, front office staff, other physicians in your practice, and even medical assistants if you have them working in your practice. This is also a great way, identifying somebody who's going to be a quality and safety champion is also a way to advance somebody in your practice that is looking for growth. I know from my experience, that's kind of how I got into the quality and safety end of the practice I worked for. These individuals are the eyes and ears of your office. Their role is to provide feedback to the medical and technical director. They often participate in process improvement plans, and they may even assist in accreditation. How do you identify these individuals? How do you know who's going to be involved in this? What sets them apart? Well, first of all, they generally always plan ahead. For example, they prepared for the next day by organizing tasks and paperwork. This is your front desk person that has everybody lined up and make sure everything's ready so they walk in the door and start the day on a good foot. They also take initiative to assure details like implants for MRIs, and insurance information is confirmed before the patient even arrives. They understand or are willing to learn patients' rights, especially HIPAA, and they are comfortable bringing deficiencies to your attention. For instance, they point out ways to improve efficiency in the office, and they will point out areas to you where they feel extra training may be needed. Let's face it, everybody acts to their highest behavior when the people in charge are immediately present. So you kind of need somebody that's looking at what's happening all day, every day. For the people and to compensate for maybe parts of your staff and your team that aren't so involved in this initiative, there are many facets, but most of them come down to what I like to call the 4 C's. First being communication between stakeholders. We all know communication is very important. Communication errors have the potential to result in injury to a patient or a provider. They can also lead to misdiagnosis and treatment complications. Effective communication with the team about quality and safety challenges and initiatives can help assure that incidents are kept to a bare minimum. Miscommunication can occur in countless ways, unfortunately, but let's look at a few. Scenario: it's a typical Friday afternoon at your facility. The waiting room is absolutely packed, and the only person that wants to get out of there more than you and your fellow teammates is the patient, who was under the impression that they could walk right in and be seen right away. So you go out to the waiting room and you call Mr. Bones back for a CT of his sinuses. You're in a hurry, and Mr. Bones is not a common name. You bring the patient back. You are putting him on the table as you're asking his symptoms and getting him set up for the exam. And he tells you he has migraines. It's allergy season, so you quickly do a scan and get him up. As he is walking up front, the receptionist calls back, and she asks you why you took Mr. Davy Jones back for his CT of the brain before you took Mr. Bill Bones back for his sinus CT. And now your afternoon just got a lot longer because your facility's patient identification policy was either not followed or not adequate, and now you have a lot of paperwork to do. This is why you must have a compliant patient identification policy that everybody follows. Other examples of miscommunication are the wrong protocol because the proper indication was maybe not written on the order, or the order was misread by the technologist, or not obtaining a full history from the patient that may result in wrong side of the body being imaged. The order says left knee, it's really supposed to be the right knee. If you don't talk to the patient, you may not realize that there was an error ordering. Also, I've had patients many times order for a CT of the chest with contrast or shortness of breath. But if you do not get the patient to give you a thorough history, you may not know, or the patient may not tell you that, hey, they had a DVT last week, and then you might not realize that they really need a PE study. So communication between everyone is just very important. There are several strategies that can improve communications in medical facilities, such as team huddles. If you're huddling up in the morning, maybe once a week you have a quality or safety tidbit that you bring up, or maybe somebody's come to you with a near miss and you talk about that without making anybody feel uncomfortable. I hope you're rounding. Everybody should be rounding, kind of unobtrusively sitting in the waiting room, or kind of listening to what's going on in the different areas of your practice, to give you an opportunity to have one-on-one conversations with employees and maybe give them guidance. QI meeting minutes are a great place to talk about quality and safety. It is a quality meeting. I suggest you open the floor and ask during the meeting if anybody has any concerns. I would also try to have some sort of method of anonymous reporting for your staff, so that if they don't feel comfortable, some people just don't feel comfortable verbalizing things in a group, or they don't want to be known as the person that brought this to attention. So if you have that, you may have a lot more participation in possible issues in the office. The other thing is it's really important is onboarding or employee orientation. Make sure you do safety information the very first day, because anything can happen at the office at any time, and you might find somebody new standing in the MR unit with something they're not supposed to have, or going into a hot lab that they're not supposed to be in. The other thing that's good, that kind of falls under communication, is emergency drills. I don't know if anybody drills stuff out, but especially for incidents that have potential to harm a patient or employees. For instance, does your staff run mock codes for MRI? Do you have a set method for getting the patient out of the MRI suite if there's a medical emergency, and do you actually drill it? Do they know where to take the patient and where the drug box is and AED are for other emergencies? And another important one is, who is tasked with waiting outside for the emergency responders? The last thing you want is for a safety incident to occur on top of a medical emergency. And having a policy, although necessary, is just not enough. If everybody in your office doesn't know what to do and they haven't acted it out, reading the policy or remembering what the policy says in an emergency, that it's not going to be very helpful. Okay, the second C is consistency in the imaging space. This assures quality by eliminating variability of operating procedures, imaging protocols, and report content from visit to visit, and despite which providers within the lab are performing them. Consistency is the foundation of solid management, based on standardized policies, protocols, and procedures. Not only do patients require and deserve consistency, but also other stakeholders, such as the other care professionals and ancillary support staff throughout the facility. Some examples of consistency are, well, referring back to our Mr. Bones, Mr. Jones mix-up, if all technologists strictly adhered to the policy of asking for a second identifier from the patient, like first name or date of birth, this incident would have been avoided, and the technologist and manager would have started their weekend much earlier. Procedural consistency is following the same steps every time. For example, when I managed an imaging center, my team and I prevented many MRI accidents with a simple technique. When our toe touched the threshold of the MRI door, you know, that little jump up, we would always say two things. First of all, watch your step, because everybody trips over that. And for your safety, I need to ask you one more time. Do you have anything in or on your body that you were not born with? We consistently ask that. That was the most basic, boiled down question I could ask a patient. And you'd be surprised, no, you probably wouldn't be, how many people get to that door and you ask them that question, they're like, well, there was this one time. Or, well, I do have something pierced. Sometimes they're answering questions or just blindly answering, or they just think, well, they're not talking about this and they're not talking about that. Consistency in protocols is vital for many reasons, but one of the most important is that if you are following a disease progression or following up on a finding, it is hard to compare two exams that were performed at different delay intervals for contrast, or if the slice thickness or the angles you're scanning are altered. The third C is coordination of care. Coordination within an imaging lab is also important and involves working with various departments to assure unified care. In a multidisciplinary lab or healthcare system, it is important for departments to work together to meet the patient's needs. This includes assuring that reports reach treating physicians in a timely manner to facilitate follow-up, and different departments must also be aware of diagnostic tests that have been already performed and their findings. This helps to ensure that studies are not repeated and assists with choosing a protocol and customizing the exams to the patient's case. Some example of coordination are calling the MRI technologist to give them a heads up to have a rad look at Mr. Smith's CT before they scan him, because you never know because you know the report won't be in the system yet, and there are specific findings that need to be assessed in the MRI scan. If you don't do this step, they might just do the scan and then, oh, we didn't realize he had a positive finding on another exam. Or looking for prior studies on your patient the night before so you have reports and protocols ready. Also, it's helpful to call the patient's referring physician to get reports from any prior exams if the order says follow-up, but they weren't scanned previously at your facility. Again, the night before. I realize some technologists will be on top of this and they will automatically do it, but if you have people you're not getting buy-in from, having a policy and a procedure will help eliminate the panic, like a panic at the disco when a patient shows up and you don't have what you need. Going one step further and providing a patient with a copy of their study on a disc if you think they may get referred to a specialist outside your network, or they've told you, so that they don't have to come back and pick up a disc. Finally, continuity in patient care, which is the ability to provide imaging and reporting which follows the protocols and best practices that set the standard of care for patients. Providing continuity of care assures that patients are receiving treatment that is equitable and appropriate. Focusing on the 4 C's helps to assure safe, quality care every day to every patient and by every provider. It also facilitates communication between team members in the office, between offices in the practice, and between all stakeholders in the patient's care while following standard of care and best practices. To highlight the 4 C's, let's visit that recent incident where the nurse was pinned to the MRI unit by a patient bed. Communication between the staff, including MRI safety training for all hospital staff, can help mitigate these type of accidents. The consistent act of closing the MRI door always can also deter these incidents. Coordination between the floor nurse and the MRI department before the patient is brought down into bed could allow the technologist to remind the nurse again not to enter the room until they are with them. Continuity in this situation would be if all facilities in this healthcare system and all outpatient offices use the exact same procedure when bringing the patient in a bed or in a chair, or just bringing the patient into the room, into the MRI suite. If everybody does it exactly the same in every location, as we know, everybody's short, nurses and techs and physicians, then everybody knows what's going to happen next, and it cuts out some of the opportunity for error. Now that we have our internal team set, active and communicating, you want to make sure that you have the right players for the duties performed for and outside of your organization staff. Think of these roles as your special teams roster. Your outside team members are a group of professionals who are instrumental to assuring quality and safety within your imaging program. They are physicists, service engineers, and an accrediting organization. You may have others like you might have people that come and assist you with protocols, do extra training. There's all kinds of outside stakeholders, but these are the three main that everybody needs. Just like having people in place in the office for certain roles, who you choose for these outside team members is crucial to your success. You are probably aware that you have a medical physicist who does an annual survey on your equipment. But what exactly does a medical physicist do, and how does their role help assure quality and safety? The medical physicist's role in quality and safety are to educate the staff on radiation safety, if it's a machine that produces radiation, oversee the quality control initiatives of the practice and the routine quality control being performed, assure accuracy of radiation dose if appropriate, and assess the resolution of the scanners. When choosing a physicist, you want to assure that they are familiar with your accrediting body and the requirements and the tests to be performed. You want to make sure they have the proper equipment to perform the tests. If they have equipment that you don't use in your daily use, but is needed for their part of quality and safety, it always helps if they have that they have those phantoms or equipment, because that's a cost that you won't incur then. And you want to inquire about their added value offerings like radiation safety training lessons, because you also need that. These are items that can add up in cost if you need to supply them separately. The service engineer. Everybody loves the service engineer. We know main function, or it seems like the one that's most important to us, is repairing your imaging equipment when it goes down. But they are also responsible for initial installation of imaging equipment and maintaining the imaging equipment. When looking for a service engineer, the important factors to research are they familiar with your specific scanner make and model? Like vehicles, scanners have different specifications and nuances that must be maintained. Will they guarantee PMs are performed to your manufacturer's specifications? And are repairs included in your contract, or are they paid on an hourly basis? Contracts can be written both ways. And will they guarantee a window of time to come out and assess a machine that is down and start repairs? Because the last thing you want to hear is that your engineer can't come for a week and you have a waiting room full of patients and a stack of patients on the schedule for the foreseeable future. Remember, a bargain is not always a bargain in the end. And finally, an accrediting organization. You may be asking yourself, why do we need accreditation? I'm sure you're asking yourself that when you're filling out the application that you're struggling with, and it's all of this information they're asking and all these requirements coming at you. But in order to really talk about that, I like to start at the beginning and kind of go through why. If you're a medical professional, imaging professional, you know who this man is, and you most likely know what the image is next to it. This is Wilhelm Röntgen. This is the very first X-ray picture that was ever taken, and it was of Mrs. Röntgen's hand. And this was in 1895 when he accidentally discovered X-ray. Everybody knows that story. But this picture you may not know about. Also in the year 1895, Thomas Edison started experimenting with X-ray, and he actually was the inventor of the fluoroscope. he's the one looking through the apparatus. The other gentleman is Clarence Daly. He was the assistant on this project, and Mr. Edison was very fond of Mr. Daly. And in 1895, when they invented the fluoroscope, it was a huge success. They were traveling all over the country, going to these high-profile doctors and high-profile cases, and they were showing them how they could look at live X-ray, and everything was going great. But in about 1901, Daly started losing his hair. Now, he was a middle-aged man, and I'm sure nobody thought too much of it, but in late 1901 and early 1902, he began having swelling in his hands and necrosis of his hands. He had to have them amputated, and he did eventually die of radiation poisoning. Now, when his health started going south, Edison abruptly quit experimenting in X-ray. So if you haven't ever heard of his association with it, he kind of did his best to distance himself from that part of history. I love this picture. This is actually one of his fluoroscopes. They have it on display in Fort Myers at the Thomas Edison and Henry Ford Museum. If you ever get close to Fort Myers, I highly recommend you go here. It's a beautiful estate, and they have a lot of artifacts from Thomas Edison. And they also have a laboratory that Edison and Ford used to go in and tinker in the winter when they were wintering in Florida. So if you're in nuclear medicine, you definitely know who this woman is, Madame Curie. She discovered the medical applications of uranium when she was working in Paris around 1898. She was so excited about uranium and its use that she carried it around in her pocket, and she gave it to other scientists. She also carried her notebook in the same pocket. Marie Curie died in 1934 from aplastic anemia, which is contracted from her long-term use of radiation and exposure to it. Fun fact, by 1934, they knew enough about radiation safety and poisoning to bury her in a lead-lined coffin. It is estimated that her notebooks will be radioactive for the next 1,500 years. And one more just radiation fact or radioactive fact for you that's a little obscure. In the U.S., around the same time that Madame Curie was working with radium, during World War II, women worked in watch factories, and they were painting watch faces with radium paint. In order to get the paintbrush into a fine line, so they could paint those tiny, tiny numbers that would glow in the dark, they used their mouth. Gross, but it's true. These were very prestigious jobs because they paid very well, and working with the paint gave the women a glow and very white teeth. It was very unusual. It attracted a lot of attention. A lot of women wanted to work in these factories. Unfortunately, these women's teeth started falling out, and their jaws began to crumble, and many of them died. If you're interested in this history, I highly recommend reading the book, The Radium Girls by Kate Moore. It's very well written, and it's just fascinating. At least it was to me. So moving on to radiation protection, the first lead aprons were manufactured around 1920, although not widely used. And this group in 1920, these individuals formed what would become the ASRT. In the 1950s, this association created the first standards for X-ray technologist training curriculum, which could be considered the very first initiative to assure quality and safety in medical imaging. Isn't it interesting? They were technologists, not physicians. We also know that medical imaging has evolved from a hand X-ray in 1895 to the wide array of imaging modalities that it is today, and that each modality has its own quality and safety concerns. And by the early 1990s, it was becoming apparent that there was a need to standardize and regulate radiology practices to help assure quality and safety. In response to the need to ensure quality and safety, medical imaging accreditation organizations emerged. And in the late 1990s to early 2000s, two accrediting bodies, the Intersocietal Accreditation Commission and the American College of Radiology, began developing standards for various imaging modalities. This helped address the concerns that were emerging regarding the need for standardization to ensure safety and quality. In 2008, the MIPA Act was put into law. This mandated advanced diagnostic imaging provided in the outpatient setting be accredited by January 1st, 2012 in order to be reimbursed. That's one of the whys we need accreditation. But why the growing connection between accreditation and reimbursement? Well, the government started feeling that there was an increased utilization of diagnostic imaging in general, to the point they felt maybe overutilization. They also noticed a lack of quality and consistency and a lot of repeat exams. And their assumption was that accreditation could and would help to control those issues. I think it's interesting to think about, because I think some people think that accrediting bodies were a response to the MIPA Act, but we were actually accrediting facilities who wanted to assure quality and safety a good bit before they actually put that into law. So, accrediting organizations' role in quality and safety. Well, they provide standards for quality and safety for your practice. They provide guidance to facilities in quality and safety matters. And that's just not written guidance. That should be, if you have a concern, being able to contact your accrediting body and discuss whatever that is and kind of talk it through and have them help you come up with a solution. And they should provide resources to assist the facility in complying with quality and safety measures, not just help them comply. When choosing an accrediting organization, you should consider, do they provide strong customer service from clinical professionals on staff that can speak at a clinical level, technical level, about producing quality images? Someone who has worked as a technologist and has medical imaging credentials. Does their staff have real clinical experience? Have they been in the role that you are in or something similar? Do they understand the challenges and differences of various practice types? For instance, small practices, single practitioner offices, and large practices, which all have unique challenges and needs. Do they offer tools to assist you with compliance? Do they offer templates and guidance documents? In other words, have they been in your shoes? When you call them and you ask them or you present your issue, do they fully understand what you need and how this is affecting your day-to-day operations? I'm sure you're wondering how accreditation really improves safety. I mean, believe me, I used to be in private practice. I wondered the same thing. I had the same thoughts when I would have to do it. To understand this, though, I encourage you to look to the available resources that are provided by your accrediting body. And what are these resources? Well, to start, I would like you to invite you to look at the accreditation process through a new lens. This process itself is an improvement activity. It gives you the opportunity to identify areas for improvement in your practice. It is also a chance to refresh staff on policies and procedures and to make sure your policies and procedures are up to date with the mandates that are in place. It's also a way, depending on the accrediting body, to get objective perspective on case and reporting quality. Remember, your accreditation team at the organization can also be a valuable resource, especially if they have clinical background, if they understand the unique challenges that you may be facing in your practice. They should give you individualized assistance to make this process as valuable and seamless as possible. Accreditation should feel like a team effort where you have somebody who is coaching you and showing you the way to be compliant if you don't understand. They should have resources that add value to your practice as well. And we're going to discuss some of these resources in the next section. Having a continuous improvement plan is vital to quality and safety and part of accreditation. As you can see here, attention must be given to many diverse factors that affect quality and safety goals. This may seem overwhelming and a costly endeavor, but if you partner with an accrediting body who plays an active role in these initiatives, you will find that the tasks become less cumbersome. Participating in continuous improvement activities has many benefits. It helps create a culture of quality and safety. It can improve productivity. It provides consistency in care and ensures appropriate reporting and imaging. And many QI initiatives can count towards maintenance of certification and merit-based incentive payment system activities. We at the IAC are so passionate about our mission, improving healthcare through accreditation, that we have created tools and resources to assist you with achieving and maintaining quality and safety. These resources are actually available to all imaging labs despite their accreditation status or their accrediting body. They are available on our website, intersocietal.org. Quality improvement resources that are available on the IAC website to all facilities include a template for QI meeting documentation and a QI tool for case review. This QI tool is designed to assist with performing self-assessment and peer review of cases, recognizing deficiencies, implementing a corrective action or process improvement plans to address the deficiencies. It will also help you benchmark your findings. In addition, it can be used to help satisfy MOC activities. The IAC is proud to offer this complimentary online QI tool that can be used for the assessments of your case studies and for your required QI activities. To use the IAC QI tool, you would log into your IAC account or create an account and click on the Quality Improvement tab to access the QI tool. Here you will create a QI assessment activity and choose cases to review. You then assign the cases to your staff, and they will do a quick review of the case study. They get an email that says you've been assigned a case review. It asks about the image quality and asks some very targeted questions about the report. The whole process takes less than 10 minutes to review a case. And there is a short video if you just want to create an account and look at it. There is a short video that explains how to use the QI tool in the middle of the page, on the landing page for that tab. Once you've completed the QI process and the reviews are submitted online, the IAC will provide a comprehensive overview of the results. As you can see here, this is an example. This is a quantitative report that identifies opportunity for process improvement. These results can also provide a data-driven measure of QI progress over time. They can also be used to discuss areas for improvement in your QI meetings. These QI meetings are required to be compliant in your accreditation, no matter what accrediting body you're using. And we also offer free special topic webinars to all facilities and individuals that provide valuable information on new developments in the imaging field and other pertinent topics. Recent popular offerings have been ergonomics for ultrasound technologists. I hope we're all adults. Novel applications in cardiac CT and nuclear cardiology lab modernization and novel applications. We also have accreditation webinars on demand that always award a CE credit. These are webinars you can view if you're interested in learning more about IAC accreditation, or I always like to use the example, if you have somebody that slides in sideways in a panic, they need 1 credit, this is a way you can get them their last credit before the last day of the month. Other resources provided through our accreditation organization are peer review and feedback through case review during accreditation process. We're really proud of that, that we help facilities not only with their imaging, but their reporting, and written standards which are created by our board of directors. We also have a full repository of sample policies to assist your facility in creating succinct, compliant policies. So if you are struggling with a policy and you find that your, for instance, medical emergency policy is 25 pages long, and you just need a brass tacks policy, you can go on there and look what we have and kind of build what it'll give you a template and a building, somewhere to start. Collectively, these public resources help to provide direction for best practices and supplement your quality and safety efforts to avoid unfortunate outcomes in your practice. Before we start the Q&A for this presentation, I want you to consider another why. Why is assuring safe quality care so important? And for me and the people I work with, it's an easy answer. Because one day, every one of us will become a patient, and so will the people you love most. And they and everybody deserves the best healthcare possible. We'll go ahead and take some questions. I just wanted to say, if you guys have any questions, you want to discuss anything, you can certainly reach out to myself. Here's my contact information. Also, I can connect you with any of the other directors, or you can go online and find the other directors. The QR code on this page is a special offering that we do when we do webinars and exhibits. If you think you might be remotely interested at looking at IAC as your accrediting body, you can fill out an interest form, and that interest form gives you 1 year to complete application, and link to this webinar, that would be at a 15% reduced rate for your base fee for your accreditation. Okay.
Okay.
Do we have any
Thank you.
questions?
I've got a couple of questions, Nancy. The first one is, how can you determine if you need a medical physicist for your MRI accreditation?
I'm sorry, one more time. How can you become a medical physicist?
No, determine. How can you determine if you need a medical physicist?
Oh, how can you determine? I'm sorry. Okay.
Okay.
So it depends on your accrediting body. So I can speak for IAC. At IAC, for MR accreditation, we do not require a medical physicist. Now, there's a caveat to if you're engineer and if you're service engineer, and this is also a good question to ask them if you're going to credit through IAC, if your service engineer is comfortable doing the coil testing annually, then you can forego the physicist and have them do your coil testing and the rest of the evaluation of your scanner. If you're using another accrediting body, the ACR, I believe, requires an annual physicist. So it depends on what the standards are for who and the requirements for who you accredit with. But for instance, in my prior environment, we had an amazing engineer, and he did the coil testing we had 14 offices. He did all the coil testing. He would do it at the first PM of the year. And that way, we actually did save quite a bit of funds by not having to bring in an annual physicist. I hope that answers the question.
I'm sure it does. Thank you. Another question here is, do all payers accept all accrediting bodies?
Yes. So CMS sets who is an approved accrediting body, and all the payers fall in line with that. Correct.
Perfect.
I know
Okay.
people get nervous about that.
Another question here is, will service reports be part of the accreditation process?
So if we're talking about preventative maintenance or preventative maintenance, yes. Service reports and again, I can only speak, you know, with confidence about IAC, but we don't require you to upload any type of service that you've had for downtime on your scanner. You obviously should keep it because it's a good thing to have, but we don't ask you to upload those.
Okie dokie. Right. Just before we wrap up, Nancy, have you got any top tips to finish off the webinar today?
Yeah, so I would just say my top tips are to utilize your staff. Really look at your staff when you do annual reviews. Ask people if they're interested in quality and safety. If you can get a couple people who are really vested in that, it will really help you in the long run. And I would also say leverage your outside stakeholders, your engineer, your physicist, and your accrediting body. Don't be afraid to pick up the phone and call and get guidance or talk through an issue. And I also want to assure people, I know when I was in private practice, I would think, oh gosh, if I have to call them and ask them a question, they're going to know they're going to know I don't know what I'm doing. They're just, and they're afraid to call us and ask. But I assure you, we would rather you call and ask. If you're not sure when you're completing the application, or if you have an issue in the office, we would rather you call and ask. I promise you, we're not going to think that you don't know what you're doing. Different people in medical imaging have different focuses, and they have different specialties, and the way we all come together to help the patient.
Great. Thank you so much, Nancy, for your
Yes.
time today and fantastic presentation. Thank you. And we also want to
Thank
thank
you.
the IAC. So if you want more information about them, please visit Intersocial. I always say this wrong, don't I?
That's okay.
Intersocial.org for more information. Just as
It's
promised.
it's a mouthful.
Yeah, I know, I know. But as promised, the answer to today's trivia question is the lily. So congratulations to our winner, Amanda Hedges in California. Now, just a quick reminder, you can obtain your CE certificate by completing the post-webinar survey, which will be emailed one after the completion of today's webinar. You must complete the survey to receive your One Art Category A CE credit by the AHRA, and you'll be able to download the certificate directly from your computer once you submitted the survey. Now, if you have any questions, you can reach us at webinar@mdpublishing.com. Please visit icewebinars.live for details of all our upcoming ICE webinars and, of course, complimentary registration. And if you've missed any of our past ICE webinars, again, please visit icewebinars.live to view our whole webinar archive. So thank you all for your time today, and I hope you enjoy the rest of your day.
Thank you. And thank you for the opportunity to speak to the IAC. I'm sorry, to ICE.
Thanks, Nancy. Bye-bye.
It's a lot of acronyms.